Welcome to the Papers Podcast. This is our inaugural episode, and we're glad to have you. But this is the podcast where we review the health professions education literature, so you don't have to. The number needed to listen is 1. John's first up on our first episode with a paper from South Africa. Over to you, John.
Jason, Linda, Lara, you know how hard it is to start from scratch. And so I might be reading a little bit into this as the 001 episode, but I wanted my first selection for the Papers Podcast to reflect a little something about me and the scholarship that moves me and gets me excited. And so I think this paper is a great representation. The first and most obvious theme we're going to talk about is one of health advocacy. Jason and Linda will know this, but the listeners may not know that I was the lead for health advocacy for the CanMeds 2015 work. And so CanMeds is a global physician competency framework. And one of the 7 major themes is the role that physicians need to play in health advocacy. In fact, CanMeds has subsequently been adopted into about 8 to 10 other health professions as well. Advocacy is a tricky thing. Should all physicians do it? Does everyone have to go after big tobacco? What really is advocacy? Maybe we can have a little bit of a chat about that. And so I want to give a bit of a shout out to some of the world-class researchers who are debating and wrestling with this idea. And so I think about Maria Hubinet and Jennifer Holm, who I've done some work with. This paper also speaks to the idea of connections and friends. And I think that's really what brings me to the podcast. And I suspect it does for you as well. Connecting with people who are wrestling with similar ideas in health professions education. And so this paper for me helps tie me to South Africa, where I've had the really good fortune to recently become a friend of Flavia Senkabuke, who I think is pretty awesome and deserves her own shout out. She's a professor of public health medicine. And this is the really cool part. She's the youngest and the first Black woman to serve as the president of the Colleges of Medicine of South Africa. But the best part is she has her own Wikipedia page, so go check out Flavia.
That's awesome.
So this paper is about advocacy. It's about the international community that's connected around health education. I have a couple of questions maybe for us to start off with. And Jason, probably the most important thing is some definitions up front. How do you define or how do you think about advocacy?
So this one's a tough one because a lot of people around the world have told us that they struggle with health advocate. Out of all the CanMeds domains, it's the one that gets highlighted the most. Health advocate actually started around the year 1992 as a concept in this packaging for medical education. And it came from patients, came from a focus group with patients. And they identified as, I want my health professional to be able to advocate for me as a patient when I need to access something or for as a population when we want to improve healthcare overall. So health advocacy is about health professionals using their special expertise, their power in society to make healthcare better for individuals and populations. Also like Ivio Anderson's definition, which is, she reminds us that the word is derived from Latin to stand beside, which I think is such a cool definition.
Lara, why should a health professional be an advocate? Why is this so important? Why is this such a big influence in all of these competency frameworks that we're seeing emerging around the world?
There's a couple of things wrapped up in there, John. I think advocacy is ever so important as our global community shifts and changes, and as our thinking about what it means to be a healthcare provider starts to evolve in terms of having a broader scope. Things like the COVID pandemic taught us that public health is very much the healthcare that we see in our clinics every day. So we can't afford to not be thinking about this. And I think the other part that makes, just to speak back to what Jason was saying, health advocacy is tricky too, because it depends on who you talk to. I'm reminded of a paper that Corey LaDonna published in 2021. It's in medical education. She's a first author, and the study talked about how health advocacy means different things to physicians than it does to patients. So physicians talk about health advocacy with disruption and political activism and systems change, whereas the patients thought about health advocacy in terms of patient-centeredness and having empathy and being attentive listeners. So it's a tricky concept that we have to deal with. It's not the same for everyone.
Linda, you're an award-winning teacher. You're in a former life faculty development dean. What's your experience with teaching it? Why is it always a challenge? Why do we always get so many requests and calls and concerns from health professions educators about the nuance and the challenges with teaching health advocacy?
So I think we do teach it, but I think much of the time we teach it implicitly. We're not explicit about what we do. And if you're a good teacher and as Lara says, you're advocating for your patient and you're role modeling it, that's fine. But we often don't say, hey, you know that what I'm doing now is health advocacy. We don't say to the resident, when you went down to radiology and actually pushed to get your patient an imaging procedure, that's actually advocacy. But more important than the teaching it is my experience with assessing it. There will be a long silence here, because that's the problem with assessing advocacy. It is rarely done, or if it is done, it's not done properly. I think most people, when they see a list of competencies to assess, and health advocate is one of them, they probably put not applicable or not C, because they don't know what they're looking for. So in summary, yes, it's taught, probably implicitly, and it's probably not assessed.
Okay, so that seems like a good place to situate our conversation. Let's dive into the article. The article is by Van Staden and Duma, and it's titled The Teaching, Learning, and Assessment of Health Advocacy in the South African College of Health Sciences. It's published in the November 2022 issue of the South African Journal of Higher Education. So if you're not a regular subscriber to this journal, I'm not necessarily. We are doing the work here at the Papers Podcast, scanning all of the HPE lit to find things that we think is going to change your practice. So here's what the purpose of this study was, and I'm going to quote the authors. The research set out to investigate the extent to which health advocacy as a core competency within health professions education and training is taught and assessed within health professions training programs at a single South African university. They used a sequential mixed method study of undergraduate programs that included audiology, dental therapy, medical science, medicine, nursing, occupational therapy, pharmacy, physiology, physiotherapy, speech language therapy, sports science, and optometry. So you really see a whole collection and a whole spectrum of health professions education here. A convenient sample of 8 of the 12 curricula that were made available from those different disciplines were then mapped. They used explicit, such as the term advocate, or implicit, such as the term social justice, to identify relevant learning outcomes from the curriculum maps. Then did a content analysis using frequency of outcomes to identify common and different competencies related to health advocacy across these different health profession disciplines. Subsequent to this document review, they conducted key informant focus groups that were recruited with purposive sampling. And I promise you that I was going to say purposive,
yeah.
And I was going to change it for this podcast.
But no.
But my reptilian brain can't handle it.
Purposive. Yeah.
I'm going to, you know what, I'm standing by this. I'm going to use the word purposive for another decade.
Stand there if you want, but it's wrong, hon. I'm sorry.
It's an interesting word you've made up, Don. Again.
Yep.
It's like a neologism, isn't it? Or I guess it's not, just a mispronunciation.
No, but it's a mispronunciation, so it's a neopronunciatism.
A neopronunciationism. Okay,
it's like nuclear. It's the same thing.
I love the company that I'm keeping. Anyway, so they were intentional in sampling the people that they wanted to be a part of this group to have diversity, which is what purpose of I can hardly even say it. It's like so ingrained means.
I was cheering you on, bud. You got this.
You know what? I could see you looking at me, and I knew in my eyes I was going to screw that part up. Well done to me. The questions addressed how health advocacy is taught, assessed, and incorporated. They did a thematic data analysis of the transcriptions and the field notes. A second researcher recoded the data to ensure credibility. They identified key themes that were identified by the coding and then triangulated them back to the curriculum mapping exercise. So I'll turn to Linda, Jason, Lara for some comments about the methods.
So first of all, I think this is a really good idea. I mean, we don't really know much about health advocacy and the teaching and the assessing of it. And here's a place where, as described in the introduction, health advocacy teaching and practice is really necessary. I like the idea of a sequential mixed methods, and I particularly like the idea of it in a context where, the authors probably didn't have a huge grant to do this. So they took a lot of information, a lot of data they already had from the documents and worked with that to begin with, and then had a couple of focus groups so that they could actually clarify what they actually saw in the data and try to triangulate the two sets of results. I'm sure there's much more complex things that could be said about the methodology, but good on them for starting this way.
Yeah, similarly, I felt positive about this paper. I loved the compelling opening paragraph that said health advocacy is so critically important to South Africa right now for healthcare. That was compelling to me. I would have liked to have seen the authors write a little bit more about the existing literature on health advocate, because there is a body of literature that's out there, and that would have maybe informed their study. I would also have liked to see two other things. One was, if they're going to do curriculum mapping, I'd like to hear what that looked like. It sounded like they went through documents that were submitted to them, and they search for keywords. You could debate, well, which keywords to use, but just because a keyword is written doesn't mean it was actually taught, and it doesn't mean it was actually learned. So that's a certain level of curriculum mapping. And then the focus group is a curious choice to me. I'd love to hear what other people think about that. But if you're in a focus group with people asking, did you teach this thing that's really important? The social desirability feeling in that room is going to be really high. I'm wondering if an interview would have been a better choice for this topic anyway.
So the focus group part doesn't bother me so much, Jason, but except to note that there was a focus group of 11. And for me, 11 people in any conversation just gets hard to manage. So for me, and there's no great gravity, big thinking science behind this. But for me, typically, a focus group at 6 I can manage, and at 8 is getting unmanageable. But maybe it's a different kind of cultural context, different kinds of discussions going on. So it may not hold there. But for me, somewhere between 6 and 8 is a sweet spot. I thought the design was very clear. I really appreciated their description and their clarity on that. The study is conducted from a post-positivist orientation. There's hints of that throughout, and that's absolutely fine. Their use of thematic analysis really works for me. One of the things that's really useful in terms of thematic analysis, especially if you look at the traditions that have been created by Brown and Clark, who just recently wrote a great book on thematic analysis. So if you're interested in doing that, I highly recommend. Came out in 2022. But thematic analysis is a very flexible approach to qualitative data analysis. And so when you use it from a post-positivist orientation, they call it little q qual, which is fine. It's a really powerful tool to use for helping to do this analysis. One thing, I'm not going to steal the thunder because I'm going to touch on the results here in a bit, but I'm just going to foreshadow. One of the things that we have to remember, though, when we do thematic analysis is that a code, right? So when we go through the process, first you generate codes, then from those codes you generate themes. Codes hold on to one idea, right? So it's a single meaning unit, a single concept. Themes bring several different codes together to develop more insight, to offer a deeper understanding. I just want to put that there on our placeholder in our parking lot, because I'm going to come back to that when we talk about results. Back to you, John.
I got to stop here just to say thank you, Lara. That's the best explained of codes and themes I've heard for a while. So for you papers people, remember that as you're going to be doing some analysis with coding and theme.
Lara, do you want to say the reference one more time for everybody listening so you have to stop and rewind?
Sure. So the book is called Thematic Analysis, A Practical Guide, and is by Victoria Brown and Victoria Clark. Just a hint of the word, otherwise, though, Brown is it's pronounced Brown, but it's spelled Braun, which suggests brawn, but it's pronounced Brown. And it was published in 2022. Great book, walks you through coding. Really nicely done.
Right. So I think what we've heard is the laudable goal of doing a program eval. And so who knew we were going to do a program eval manuscript as manuscript number 1? So there's a whole bunch of meta here. A second laudable goal that Lara was able to say post-positivist without really crinkling up her face and getting hot under the collar. We'll see how long that lasts, but I'm here to defend the post-positivist. So papers listeners, you have people who are on your side. So let's jump to the outcomes. They identified They identified 6 key themes. The first was the perceived importance of the health advocate role for health practitioners. It's a necessary and valued competency to address social injustice and inequity. And I'm going to hit these at the high level, so I'll let you all dig in for a particular theme that you thought was particularly helpful. Second is implicit health advocate content is found in the curriculum, but there's not explicit inclusion of content. Only 1 of 8 programs articulated in their curriculum map, and no program actually talked about specific skills. Number 3 is health advocacy uses implicit learning outcomes. There's learning that occurs via projects and experiential opportunities, but they don't bake it in and they don't make it explicit. 4 is that a spiral curriculum approach is necessary to teach health advocacy. The differential of expectations between a novice and more experienced learner requires an iterative approach. And so that spiral curriculum model is what is recommended from this study. 5 was the need for authentic assessment of health advocacy. And this included examples of peer assessment or self-reflection or presentations around projects as common assessment methods. And the last was there's barriers to full incorporation of health advocate into the health sciences curriculum. And no surprise here, there was imprecise use of definitions and expectations, there was limited educational resources, and a lack of institutional leadership to impair health advocate curricula. Overall, the importance of the topic, as defined through the key informant focus groups, is on balance via the design, delivery, and support of health advocacy, in contrast to the importance and the necessity of including this into undergraduate training. The only other thing I would flag is that this study, as a program eval, is quite limited, as the student experience is not included in any of the data collection or the analysis. So let's do a reverse order. Lara, Jason, Linda, what do you think about the outcomes?
So thanks for letting me go first, John, because I want to go back to that comment we talked about earlier, right? How codes are one idea and themes bring more than one meaning, more than one concept idea together. So let's just look at the first 3 themes that these authors identify. Health advocacy is important for practitioners. Health advocacy is implicit in the curriculum. Health advocacy is implicit in learning outcomes. So it seems to me that those are single concepts. Those are single meanings. But if you look at those concepts in relation to some of the quotes in the paper, because there's some really great quotes in the paper, I wonder if they could bring them together to offer a larger meaning or a deeper insight. So for example, one of the data excerpts, a leader says, and I quote, "If they do not make a difference in their service, what kind of health practitioners will they be?" End of quote. So you can hear that health advocacy is foundational. It's like this participant is asking, can you even be a clinician if you can't engage in it? But also, if it's an implicit curriculum and implicit in learning outcomes, if you put that together, you can hear a tension that it's important, it's foundational, but we're not going to address it. So this is one of those places where I wonder if those individual topics are actually codes that we could bring together in a comprehensive and a broader sort of perspective to think a little deeper and push the analysis a little further.
Okay, so what I'd actually take from these outcomes, I was going to generalize it. So this is about health advocacy in the school across multiple health professions, but really this reflects conversations that happen everywhere in the world when you implement an innovation in a curriculum in education. You have issues around clarity, so defining it, getting a mental model that is shared amongst the teachers and the planners, people on the ground, the learners. And then there's the deployment through the curriculum, the sort of written, planned curriculum. Then there's, did it really happen? Is it taught? You're making it explicit in teaching and learning and assessment. And then there's is this an outcome? Does it have an impact? And I think this paper reflects that there are several examples of this being at different stages in different schools and so on. I think that's important for all of us. See, the big thing here is a lot of people don't have a shared mental model and they don't agree that it's part of our day-to-day. So it's hard for people to implement health advocate.
Yeah, I'll agree with that, Jason. I got to say, though, that many of these themes or codes or whatever you want to call them weren't really a surprise to me. It is implicit. It's probably not assessed all that well. There are many barriers, etc. I look at the teaching health advocacy in a spiral curriculum approach. And I think that's really important. The challenge is trying to teach some of this to preclinical students, and most of the students start off preclinically when they actually don't know enough about the experience and the context, can be a real challenge. So you've got a little bit of tension there. Yeah, you have to keep just building on and building on. I did like the idea of what they had at some point of sending the students back to their home and having them assess one of the potential health inequities in their home area, which can be done fairly early on. I too, by the way, think that not having students involved in this was a big loss.
All right, so the authors conclude in the following way. Health advocate is perceived as an important role for health professionals, but it's not explicitly taught nor assessed in undergraduate health sciences programs. Barriers to its teaching and assessment can be addressed through capacity development of academics. For me, I guess the final thought before we move to our round of voting is it's interesting to see this university in South Africa wrestling across 12 different health professions with problems that I'm wrestling with in my own school. And I think that's an interesting phenomenon that collectively as a health professions education community, we can articulate the value, but we're still not clear about how we might want to implement the necessary resources to enable an outcome, which is clinicians who are able to be effective advocates for their patients. So let's go to the round of voting. And I expect the moans and groans, but we're going to keep at it. If you're new to the Papers podcast, which means everybody,
because it's our first episode.
That's right. Our first vote is around the methodological quality. So it's a scale of 1 to 5. 1 is this is a terrible design. It's deeply flawed. It's fatal. We probably shouldn't even have a conversation about the outcomes because they don't matter. A 5 is this is an exemplar. If you're going to do a similar type of study, you might want to consider templating from this. And so Jason, Linda, Lara, scale of 1 to 5. What do you think about the methodological quality?
Okay, Lara's giving me faces because she knows how hard it is to be the first person to score anybody in our new podcast on the first episode. But that's okay because I'm brave and I'm going to be fair to everybody. And the methods here are 2. And they're solid, but there are 2.
So I'm going to give it a 3. Why? Because the methods were, what I might expect, probably given the resources that were probably available. No, it didn't include everything. They, perhaps the coding could have been done a little bit different. But, good on them for starting with this type of a methodology, not just sending out a survey.
So I'm going to give this a 2.5 just to watch John's head spin. No, because we made up the scale. It's got nothing to do with anything. The listeners,
it's ordinal values. It's ordinal values.
Ordinals can have a 0.5. It's a number.
No.
Yes.
Okay, your new name is Dr. Hedgie.
But I agree. So 3 is where the vast majority of papers are going to fall in the literature. It's a solid 3 is a number I would give for a solid paper, very reasonable. There are some things I'd like to adjust or tweak on this one, so a 2.5.
I am going to play by the rules because that's
what
I'm known
rules.
for.
We just made this up. It's fiction.
I'm going to tell your children that there are no rules. Self-actualization.
You meet my kids.
So I'm going to give this paper a 3. They took a big bite. And I think much like all the studies that I'm involved with, you're aspirational at the start and then feasibility creeps its way in. And so, yes, I would have liked to see some broader approaches which would add to the work and effort in terms of their key informant interviews, smaller size, more representative of a number of different perspectives, including learners. And so you could have simply done the document analysis and then provided a greater description of what you found in the document analysis. I see why it's complementary, but it leads to challenges that the document analysis is not fully explained. The key informant data is not fully realized. And so, yeah, we're at a 3. Let's turn now to the educational impact. And this time we'll do reverse order. So how important is this paper? 1, it doesn't change your practice at all. In fact, probably there's not a lot of utility in reading it because it's not insightful. Versus 5, this is a game changer. After this, you're going to draw a line or demarcate something in your educational practice, say there was a before and after, and this paper was a game changer.
So for me, this paper is again a 3. This is a place, a manuscript that is going to help inform the conversations and the research that I do in terms of health advocacy in order to really start to highlight the global challenges, the challenges all of us face around the world and trying to deal with this topic. So for me, this is a useful citation that I'm surely going to be using. So I'm going to give it a 3.
Wow. Okay, I'm glad we're not hedging anymore. So listen.
Now I'm giving it a 3.5. Just.
I'm going to turn off your microphone. I really have that power. I'm strongly considering doing this.
I don't know who gave you that power.
It's because John knows.
I got the login. I have the login. That's the only power I have.
Because John knows Samuel. There you go.
Yeah.
AKA Simon. Okay, listen. I think this is actually a 3, but for different reasons. I think it's actually a 3 because it's an example of an implementation in progress. I would put it in my health advocate file. It adds to the body of literature. And it's also a great example of implementation in progress. I could use this to stimulate a grad class talking about implementation. So there you go. It's a 3.
I would give it a 3 for a couple of reasons. One is I really think it heightens our awareness of what we already know implicitly, and that is that health advocate is likely taught implicitly and not assessed very well. It also gives a suggestion of how you might actually address this with a spiral curriculum. And it talks about barriers. It doesn't really talk about how you might address many of the barriers. It just brings them up. So it's a start. But it's certainly something, I think it's a 3 mainly because it's kind of brought this up to consciousness for me.
I'm going to give it a 4. I would say that there's a bit of selective pressure for me. I'm a senior investigator on a review of all the literature around health advocacy. It's a little out of date now. It's probably about 4 years old, and it's an AMI review. And I'll tell you that the literature around implementation is super light. And so to see an interprofessional review, even though it's a single institution, and being able to articulate these main themes, which feel real. These are the themes that we hear when we are talking about how to teach and assess health advocacy. This paper moves it forward. It articulates where the status is. It's not desirable to say this is best practices, but it's another call for us to do better because we see the disconnect. So there you have it. That's episode 1 in the can, the 001. We'd love to hear from you. You can reach us on social or at our website. We want to hear what your take is. What do you like about this new podcast? What are future topics that you want to hear debate? Do you want to give microphone control over to Lara so she can turn me off, which I know that she's desperately get the login access for?
No.
And welcome. We're really excited to be starting on this new venture. Thanks for listening.
Talk to you later.
Bye-bye.
You've been listening to the Papers Podcast. We hope we made you just slightly smarter. The podcast is a production of the Unit for Teaching and Learning at the Karolinska Institutet. The executive producer today was my friend Teresa Sorrow. The technical producer today was Samuel Lundberg. You can learn more about the Papers Podcast and contact us at www.thepaperspodcast.com. Thank you for listening, everybody, and thank you for all you do. Take care.